Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Immune checkpoint inhibitors targeting PD-1 and PD-L1 have transformed the treatment landscape across a wide variety of cancers, becoming foundational therapies in oncology. Traditionally, these agents have been administered intravenously in infusion centers. Recently, 3 agents have become available in subcutaneous formulations: pembrolizumab as Keytruda QLEX, nivolumab as Opdivo Qvantig, and atezolizumab as Tecentriq Hybreza. These new options have shorter administration times and could potentially offer advantages to health systems looking to decompress infusion centers already operating at capacity. But there are important operational, financial, clinical, and safety issues to consider first. In today's discussion, I'll explore these issues with our guest, Dr. Stacey Sobocinski, Associate Director of Pharmacy Medication Management and Informatics at MD Anderson Cancer Center, and Dr. Michele Rice, Senior Pharmacy Enterprise Solutions Director with Vizient. Stacey and Michele, welcome to the program, and thank you for joining me today. Recently, subcutaneous versions were approved for each agent in combination with a version of hyaluronidase, Keytruda QLEX, Opdivo Qvantig, and Tecentriq Hybreza, which allows for the entire dose to be administered subcutaneously. Stacey, what can you tell us about the efficacy, pharmacokinetic, and safety data regarding these new formulations?
So the efficacy, safety, as well as the pharmacokinetics have been shown to be similar between the sub-Q and IV formulations. All 3 agents were approved based on single studies, all designed fairly similarly with a primary endpoint, looking at the pharmacokinetics, really designed to show similar exposure between the sub-Q and the IV formulation. And then secondary endpoints also showed similar outcomes in terms of efficacy and safety. The only big difference seen in the studies in terms of safety was the addition of local injection site reactions with the sub-Q formulations, which is expected.
Great. Michele, anything to add?
No, I think we feel comfortable with the efficacy and safety comparison. Even though it's not necessarily established with head-to-head trials, a lot can be extrapolated from the very detailed experience with the IV formulations. What's different is what makes it a subcutaneous injection, and that's why the site reactions is the only real difference.
So that's good to note. Given these are subcutaneously administered, the workflow will look very different from the IV formulations for the subcutaneous formulation. Are there potential advantages associated with decreased infusion and observation times?
There's definite change in operations as these drugs are adopted and as more of these subcutaneous formulations become available. There's a perceived patient benefit to the shorter administration time. Whether that is a real benefit or even significant difference in chair time remains to be seen. For a drug, an IV formulation that has a very long infusion, the short sub-Q injection is very noticeable. But for a drug that is infused over 30 minutes as opposed to a 5-minute subcutaneous injection, so much of the visit is not just sitting in that chair that I'm not sure the patients will really notice a difference after a while, because you're still coming, you're still in the waiting area, waiting to be called, waiting for lab results, seeing the provider. So the bulk of the actual time will stay the same, but that's part of the myth of chair time. Would you agree, Stacey?
I definitely agree. Comparing to some of the other biologics that have had subcutaneous formulations come to market after IV, where we've seen a dramatic difference from a 5-hour infusion to a 5-minute infusion. We've seen that clear benefit, but it's to be determined what the true benefit is in terms of chair time.
Also, it's good to remember that these are not small volume injections. While we say 3 to 5 minutes for injection, it may actually take longer to push volumes up to 10 and 15 mLs into that subcutaneous space. That's been a concern for nurses in giving these agents.
Yeah, we always think about the shorter infusion time with subcutaneous, but it is dedicated time that's required for the nurse to stand there. In contrast to an IV, where once the IV line is placed, the nurse sets up the infusion and is able to complete other tasks during that infusion. That's some of the debate around nursing time with these agents. One of the potential solutions I've heard is possibly using a syringe pump to infuse these sub-Q injections. And one challenge is not all adult population infusion centers have a sufficient number of syringe pumps. It's not common practice. Most chemotherapy agents are IV infusions and administered from a bag. And so there's large volume pumps, not necessarily syringe pumps. While maybe a viable solution, it may be an additional expense for organizations to go that route.
It sounds like there's more to this initially than meets the eye in terms of what is going on operationally behind the scenes. It's interesting what you talked about with the 5-hour infusion time going to maybe 5 to 10 minutes. That's a much bigger delta than going from 30 minutes to 5 minutes. Something important to consider. Speaking of important things to consider, there are also important financial considerations beyond acquisition cost, including reimbursement and a really hot topic right now, optimizing site of care. Michele, how does the advent of subcutaneous PD-1 and PD-L1 inhibitors, how do you view it through the lens of site of care consideration?
First of all, remember that these subcutaneous formulations are being developed and promoted by the same manufacturer as the IV formulation. Right now, as an introduction, they're priced somewhat at parity, not much difference between a dose, although the different milligrams, similar cost. I would expect that to change over time, that the subcutaneous formulations will become less expensive or there'll be price competition on some front because the manufacturers are highly incentivized to get as many cancer centers switched over to the subcutaneous formulation as possible before the advent of biosimilars when these drugs start to lose their exclusivity in a couple of years.
Stacey, how do you think that's going to play out at organizations?
It'll be interesting to see how it plays out. It may differ depending on sites of care. For those organizations that offer those different sites of care, there may be more of an advantage of these sub-Q formulations in a physician clinic or possibly a freestanding infusion center, where maybe there is more of a reduction in the time that a patient spends getting these infusions. So we may see we have the timing of those patent expirations in mind, knowing that biosimilars are only a few years away for some of these agents. Do we see that true benefit to our patients, or do we continue using the IV in anticipation of the lower cost biosimilars that may be coming soon?
I totally agree. There is an advantage to the shorter chair time if a center can construct operations around that. The ones that are going to do best with this will have maybe a dedicated injection area or a nurse that's dedicated to subcutaneous injections so that they can leverage that short infusion time. Almost like an express lane where the patients that are on those drugs can move into chairs that turn over a lot faster than IV infusion chairs. Without that, I'm not sure that the center will see that chair time advantage and whether patients will notice either at that point. Payers will become a factor very soon. If the subcutaneous is perceived as cheaper or easier, they will start to restrict site of care. And I would expect to see such restrictions attempting to move out of the hospital outpatient department and into other less expensive sites like physician offices.
Which would be a big change for organizations to start to see in-office PD-L1 and PD-1 inhibitor administration, correct?
Absolutely.
Yeah, I agree.
It's really not as simple as just flipping a switch and going to sub-Q.
It rarely is.
Right? It rarely is. This isn't just, all right, we're just going to change all those order sets and be done. There's a lot of nuance to this, not just clinical, but operational, financial, and interdisciplinary involving nursing time. Lots to consider. As we think about this, what are some important questions for organizations to consider when choosing between IV and subcutaneous versions of these products?
It's a good idea for institutions to keep an open dialogue with their primary payers, because even if you decide not to make use of this formulation, if you have a major payer in the area that intending to drive prescribing in that direction, you'll want to be prepared so that you can take advantage of what advantages are there for you.
As wearing my formulary management hat, anytime a new dosage form comes to market of an existing product, we have a healthy level of skepticism, or at least asking ourselves, what value does this bring to our patients? And like I alluded to earlier with some of the other sub-Q formulations of biologics where there is a great advantage or that dramatic advantage in moving from IV to sub-Q, we don't have that here. So seeing what true benefit there is to your organization in that sense, there's not a tremendous advantage in terms of safety. The safety profile is pretty similar, but we do want to consider who would these products truly benefit. We do think there's possibly some advantage in our patients who are receiving monotherapy. If you have a patient who already has an IV line for other treatments that they're receiving, we may not see the same advantage. The patient may already be taking up that 1 hour time slot or 2 hour time slot anyway for those other combination treatments. That may not be a patient population where you see the benefit, but possibly in a patient who has difficulty with line access and only receiving monotherapy, there may be a role there.
By the same token, many of our patients are very low muscle mass and cachectic because of their cancer. That would also be a concern, pushing that high volume into a very small subcutaneous space. I've heard some physicians say they didn't want to make a widespread decision because assessing how hard or easy that person's going to be to access might be the driving force for their preference.
This has been terrific. Much more than meets the eye. Just simple shift, and there are lots of patient-specific and organization-specific factors to consider in PD-L1 product selection. Stacey and Michele, it's been a pleasure having you. Thank you so much. We all need to continue to monitor this issue. Things like observation times are still evolving, as well as trying to standardize administration time. That is also evolving. So we'll be looking for more best practices and evidence evolving around those issues as well. Thank you.
Thanks for having.
Yeah, thank you.
Thank you to the listeners of Verified RX. We'll see you again next time.
Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified RX is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.